Hello, and welcome to our GS at Home language course. My name is Klaudia Grechuta, and I'm a postdoctoral researcher in SPECS Lab at the Institute of Bioengineering of Catalonia. And in this particular tutorial, we will address the challenge of speech and language rehabilitation after a stroke. I will first present you what is the burden of aphasia, then we will talk about standard approaches to the rehabilitation of language, and finally I will present you on how we address the neurorehabilitation of language based on scientific principles. So aphasia is a condition that impairs the ability to communicate due to deficits in comprehension or production of language, or both. Most of the times, aphasia occurs as a consequence of a lesion in the left hemisphere, such as visualized here in the MRI scans. Aphasia is a particularly challenging condition for a number of reasons. First, very few people actually know about it. Indeed, in a recent study, it was shown that out of around 3,500 people, only 37% ever heard of aphasia, and only 9% had a basic understanding of what it was. Strikingly, the equivalent values for Parkinson's disease are 96% and 31%, and for stroke, it's 99% and 53% respectively. Another challenge regarding aphasia and its treatment is that people with aphasia are often not considered in clinical studies. This happens most commonly due to the fact that aphasia is normally one of the exclusion criteria both in experimental studies as well as meta-analysis or reviews. Here are some examples of impactful research that aim to investigate intervention principles or information giving or depression levels, which did not even consider aphasia at all. This is very much at odds with the fact that 30% of stroke patients suffer aphasia and 20% of those individuals remain chronic. The paradox of the recovery from aphasia, especially at the chronic stage, is that the best way to regain language function is to actually use it. However, as it is in the case of Broca's aphasia or non-fluent aphasia, where the production of language is impaired, the use of language is very limited. This in turn creates the so-called vicious cycle, or the learn non-use, whereby the failures to understand language very negatively impact social life, affecting mood and motivation and limiting the use of language even more. So the big question that remains unsolved is, how can we reverse this vicious cycle and promote recovery of language in people who suffer aphasia to increase their well-being and their quality of life? Well, commonly, language disorders are treated in the context of a standard therapy. The sessions include a therapist and a patient, and the training commonly includes repetitions, naming of different stimuli, spelling, syllabifications, articulating words, and similar exercises. The dosage of such training is around 30 to 40 minutes per week. Although common practice, however, is and standard therapy has been recently very much criticized. First, the language is practiced in behaviorally irrelevant context as compared to the usual use of language in everyday life. And second, the dosage is not sufficient to trigger long-term rehabilitation effects. So how can we then build a more effective therapy? Well, one of the ways to do this is to look at the neuroscientific basis of how language works in the brain. Indeed, current insights demonstrate that language doesn't work as a separate module, as previously believed, but rather it is very much linked to motor systems. Moreover, we find evidence that concepts like telephone are represented in a multiple way in the brain. So for example, a word telephone activated the brain regions in a very similar way that the pure sound of a telephone activates the brain. Also, reading words does not activate classical language comprehension hubs as previously believed, but rather the activity spreads in a number of cortical regions, suggesting their involvement in language processing. So what we proposed here is that for a therapy to be effective, it needs to combine scientific principles and exploit them during the rehabilitation training. Indeed, one rehabilitation technique which already pursues such an evidence-based approach is the so-called intensive language action therapy. It is a therapy that includes 3 patients and 1 language therapist, and which has the form of a language game, similar to a card game. So what it is important here is that ILAT promotes language use in a goal-oriented manner. Also, since the players are handing each other cards, the therapy involves the motor system, promoting social interaction at the same time. Finally, ILAT is a high-intensity training. Indeed, as you can see on the right plot here, ILAT has significantly better therapy effects than the previously discussed standard approach to language treatment. Despite its effectiveness, however, ILAT presents several limitations. For example, it does not include the multimodal cues, such as the sound of the telephone when you want to say telephone. Also, it is not accessible for all the patients, and it involves an active supervision of a specialist. So we wanted to address those limitations of ILAT by devising a virtual reality-based setup and testing it in the context of a randomized controlled trial. Specifically, we designed a multiplayer game where 2 patients play with each other by requesting or collecting objects. As you can see on the image here, their hands were tracked by an infrared sensor and mapped onto the avatar's hands so that they could interact with the virtual objects. They could see the scene from the first-person perspective as well as their interlocutors, and whenever they touched an object to be selected for a request, this object would trigger the corresponding sound to facilitate the word retrieval. The game started when the first player placed their hand on the object that they wanted to request from the interlocutor. Then they had to verbally request this object. When the interlocutor understood the request, they could pass this object on to the first player by placing their hands on top of it. After such successful communication, the players would get points and the turn would change. In our clinical study, we compared the effects of this virtual reality-based therapy to a standard therapy described previously. In both groups, we used the same absolutely materials, with the difference that in the standard therapy, there were cards, and in our case, there were virtual 3-dimensional objects. And we included individuals with non-fluent aphasia at the chronic state. When we examined the results from the main outcome measure, that is the Boston Diagnostic Aphasia Examination, we found that all subjects improved after 2 months of the treatment, as well as at the follow-up, that is 2 months after the end of the treatment. Importantly, during the follow-up period, subjects could not undergo any type of language therapy. When we further explored the differences between the groups, we found that 2 months after the therapy period, both groups significantly improved at the PDAE scale. However, only the experimental group that used the virtual reality peer-to-peer system retained those changes at the follow-up period. These results demonstrate that the proposed system promotes not only the recovery of language, but also its retention at the long term. We believe that some of the components of the therapy that contributed to these changes include the training components, that is the embodied sensory motor and goal-oriented type of training, as compared to a linguistic and impairment-focused standard therapy. Also, we believe that the training of the verbal communication may be more beneficial than the training of naming per se. And finally, we propose that patients in the experimental group benefited from peer nature of the therapy, whereby they could practice an actual real lifelike communication. Regarding this last therapy component, we propose that in our approach that we addressed here, we previously discussed this vicious cycle. So we addressed this vicious cycle by the communicative nature of the therapy, such that the intervention positively influenced social interaction and the use of language, which impacted mood and motivation, thereby triggering higher use of language and improved communication even after the end of the treatment. This hypothesis is supported by other studies which show that social interaction is critical in language recovery. To sum up, based on our results and other evidence, we propose that for a language therapy to be effective, it needs to satisfy 6 principles that include the use of language, social interaction, goal-oriented practice, multimodal cues, and embodied action context, as well as high dosage and intensity. So based on all the information that we have learned today, I would like to ask you to think of an answer to the following question. Could we use a similar treatment to foster the recovery of language in people that suffer different types of aphasia, such as Wernicke's aphasia? And if so, why? Please feel free to use any type of source of information, such as internet or any other, to find the correct answer to this question. This will be all for today. Thank you very much for listening.